Dehydration because of the expanded intravascular space and increased third spacing of fluid. Patients have a difficult time maintaining their intravascular volume status. Dietary recommendations should include increased fluids. As mentioned above, dehydration may lead to uterine contractions, possibly secondary to cross-reaction of vasopressin with oxytocin receptors. Edema, compression of the inferior vena cava, IVC, and pelvic veins by the uterus can lead to increased hydrostatic pressure in the lower extremities and eventually to edema in the feet and ankles. Elevation of the lower extremities above the heart can ease this. Also, patients should be advised to sleep on their sides to decrease compression. Severe edema of the face and hands may be indicative of preeclampsia and merits further evaluation. Gastroesophageal reflux disease, relaxation of the lower esophageal sphincter and increased transit time in the stomach can lead to reflux and nausea. Patients with reflux should be started on antacids, advised to eat multiple small meals per day, and should avoid lying down within an hour of eating. For patients with continued symptoms, H2 blockers or proton pump inhibitors can be given. Hemorrhoids, patients will have increased venous stasis and IVC compression, leading to congestion in the venous system. Congestion of the pelvic vessels combined with increased abdominal pressure with bowel movements secondary to constipation can lead to hemorrhoids. Hemorrhoids are treated symptomatically with topical anesthetics and steroids for pain and swelling. Prevention of constipation with increased fluids, increased fiber in the diet, and stool softeners may prevent or decrease the exacerbation of hemorrhoids. Vicararily, a patient will have cravings for inedible items such as dirt or clay. As long as these substances are non-toxic, the patient is advised to maintain adequate nutrition and encouraged to stop ingesting the inedible items. However, if the patient has been consuming toxic substances, immediate cessation along with a toxicology consult is advised. Round ligament pain, usually late in the second trimester or early in the third trimester. There may be some pain in the adnexa, lower abdomen, or groin. This pain is likely secondary to the rapid expansion of the uterus and stretching of the ligamentous attachments, such as the round ligaments. This is often self-limited but may be relieved with warm compresses or acetaminophen. Urinary frequency, increased intravascular volumes and elevated GFR can lead to increased urine production during pregnancy. However, the most likely cause of urinary frequency during pregnancy is increasing compression of the bladder by the growing uterus. A UTI may also be present with isolated urinary frequency but is often accompanied by dysuria. A urinalysis and culture should therefore be ordered to rule out infection. If no infection is present, patients can be assured that the increased voiding is normal. Patients should be advised to keep up hydration despite urinary frequency. Varicose veins, the lower extremities or the vulva may develop varicosities during pregnancy. The relaxation of the venous smooth muscle and increased intravascular pressure, probably both, contribute to the pathogenesis. Elevation of the lower extremities or the use of pressure stockings may help reduce existing varicosities and prevent more from developing. If the problem does not resolve by 6 months postpartum, patients may be referred for surgical